I've been speaking now about sleep and DemiPost for many, many years, and pharmacy too. I do a lot in specialty pharmacy world as well. And one of the interesting things I always tell people is my first experience into sleep was I had this pulmonologist came to my department and they said, you know what, we need to send this person home, but we want to try the CPAP thing at home. And I said, CPAP at home? They said, yes. Now, I won't tell you what year, maybe around 1980 and 81, somewhere in there. But anyway, so they said, what can you do? And I said, I have no idea. But let me think on it. So I came back to him and I said, you know what? So I went and scrounging in my department for any pieces of equipment that was just lying around that I thought could do continuous flow. I ended up with the IPPB machine. If any of y'all know what they are, if you don't, that means you're young. But anyway, so I said, let's go to an IPPB machine. We put a flow, and I had a choice of valves. I had a 2.5 valve, I had a 5 valve, I had a 7.5, I had a 10, and then I had a 15. And I said, but we had no idea what a good pressure was. We're just going to make it up, I guess. And I said, well, let's start with high to see what's going on and see, we'll just work our way down. We don't want to work up because we know right away working up once they get something that's on there. And remember, we had to find a mask too. So we pulled one off the manual ventilation bag and tried to send him home and said, you know what, guys, this is going to be good for you. Think how comfortable you're going to be. No. Well, anyway, but it went home. That was my forte into respiratory and sleep labs. And I said, and then they started doing studies, and it got special in my first CPAP machine that was an official CPAP machine. I don't know how many of y'all saw the 3 foot. It was 3 foot by 2 foot that sit beside the bed, and it went, moo! Oh, I'm sorry at home. I'm a little loud. And they said, oh, this is going to be quiet. You're going to just go all through the night with it. You're going to love it. Well, that wasn't as successful, but the technology obviously has changed a lot. And not only do we have CPAPs, we have many other varieties, Inspire. Again, it's late in the afternoon. I'm ready to go too, so I get it. So anyway, let's talk a little bit about evaluating your sleep center. One of the things I do, I work for the Accreditation Commission for Healthcare. We, along with the AASM and the Joint Commission, we do accreditation of sleep labs. But I want you to look at it a different way, because there's more to accreditation than coming in and just terrorizing you all. I mean, right? You're shaking your head, right? Because nobody really wants to see me, right? I mean, I get that. I walk in and I said, good morning, I'm here to inspect you. And they said, So I get that. I understand it. And we try not to be those people. Because at the end of the day, what I want you to do is I want you to improve the way your lab operates so you can help in the care of that patient at home. And that's all accreditation should be about, and that's all that any type of evaluation should be about. How do you make me better? It's not what you do wrong or right. I mean, you might not ever change in accreditation, and you might not want to do things that we're going to suggest. You might not be accredited then, but you know what? There's some areas you don't have to be, and that's your choice. But people that come to us, companies that come to us, either they come to us, number one, because they want to get paid. And we're going to talk about that in a minute, and everybody likes to get paid. But the other one could be very well is they just want to improve their business. And I have many companies that we accredit, because we accredit close to 700 labs, and many companies, they don't even have mandatory accreditation, but they want us to come in and evaluate what's going on with their labs. And one of the advantages of surveyors coming in is I know what I do in North Carolina, but I'm not sure what you do in Montana, right? Well, they might have a great system in Montana. Wouldn't you like to know about it and be educated about it, of what's going on? Because nobody knows everything. I might tell my kids I do, but that's a different issue. But we want to learn, and that's what we're here today to do. So as we go through evaluating your sleep center process, understanding the rules that regulate sleep testing, one of the things I'm most amazed at is when I go into sleep labs, they're not familiar with terms like NCDs or LCDs. If I say NCD or LCDs, raise your hands, how many know what I'm talking about? 3. Well, that's usually 2 more than normal. But these are some of the most important things that you deal with. And so I want to educate you on how they're set, because you as sleep providers can influence people to make the qualifications and to change this regulation. It's not easy, don't get me wrong. You can't just write a letter and, we're going to follow what they say. But what you can do is actually improve what's going on. I don't know if y'all remember when sleep labs opened up, the interpreting physician that I worked with one time was also an OBGYN. That was his specialty. Nothing wrong with OBGYN, but he'd never seen a sleep study in his life. But he said, looks like they need something. So it was a check the box. But that's what happened. And so nobody was setting regulations of what's going on. So what type of data should be collected in your lab? And what type do you think is busy work of, they just make me do this because, you know what, it's just making me do it. It's another hurdle. There's a reason for everything we ask. And there's a reason for everything maybe the LCD asks. You might not agree with it, but you should understand the reasoning behind it. The goal is to ensure that a sleep testing facility is following all the rules that private payers and requirements of regional carriers such as Medicare. And remember, not only do you have to worry about what Medicare is saying, but you have to worry about what the Blue Cross Blue Shields are saying, Humana's saying, the Medicare Advantage plans. We won't talk about that because I already got everybody else in an uproar. I didn't mean to, but got everybody in the last one, but at least I knew they were listening. So that was good. But we won't talk about that, but the whole healthcare with the Medicare Advantage plans is all changing. So what is validation? When it comes to healthcare accreditation, it refers to a review of what you're doing. Now you can read all this definition because it says it better than me, but the reality is you want to come in and be evaluated what you're doing against the standard that's out there today. I'm not there to tell you you have to do this or do that. I'm out there educating you on what the rules are for certain payers. And why do I want to do that? Nobody wants to have to pay back CMS. Nobody wants to have to pay back a payer. And I'm going to show you some instances that labs, one of them was in the Midwest. Well, one of them it was 60 of them. And they had to pay back like over $4 million to the government because they didn't follow the rules that were out there. They had wrong people doing the testing. They had OJTs with no oversight doing the testing. There's nothing wrong with OJTs. They're just rules they had to follow. So why accreditation matters? So I love this statement because I'm going to say not only am I a respiratory therapist, I have an MBA in finance. And when it comes down to it, you got to follow the money, right? I mean, that's what you got to do. So you want accreditation because you want to demonstrate your commitment to excellence. Absolutely. You want to be really good and you want to be the best. You want to give everybody the best study possible and give the best results. You want to differentiate your organization. Well, if a payer's saying you have to be accredited, then you have to be. But what if you're in an area that is not or doesn't maintain the accreditation part? And the last one is gain a partner in accreditation. We shouldn't have to come in every 3 or 5 years, and that's the only time you expect us. You need to say, hey, we heard this is going on. What does this mean? We need to be there for you to help you. It's not about just going in every 3 years or 5 years and taking a look and making you all scared. And you should never be scared of an accreditation. If you're scared of accreditation, then there's a problem. You need to embrace the education they're giving you. So NCDs. So we talked about this before. Why is this important? Because payers and Medicare sets the rules. So if you're going to evaluate what your sleep lab is doing, NCDs is called National Coverage Determination. Now I'm wobbling because I like to pace, but I'm on TV, so I can't pace. It's the kind of the dancing I want to do. So anyway, National Coverage Determination is a national rule that sets forth everybody in that area, in the sleep arena or in the Medicare arena or in the hospital arena, they have to follow the standards. There are no exceptions. There are no exceptions. So does sleep lab testing, do they have an NCD? They do not. Okay, it was a trick question. So they do not. Why is that? Because there's no national, now there are rules for CPAPs, setting up CPAPs in the home. That's covered by Medicare Part B. I'll allow it. But national coverage determination is not done for sleep labs. They are done by local coverage determination. What is local coverage determination? That means whoever the contractor is in your area monitoring Medicare, they're the ones setting the rules for that sleep testing. And you would think that would be simple and everybody'd follow the same rules. Ha! Silly you, that's just not true. It'd be too easy that way. That is the nice thing about NCDs, right? They set the rules. A contractor can make them harder, but they're at least going to tell you what the rules are. This one you're going to see in a minute. The NCDs that are set forth are kind of, the LCDs set forth are kind of all over the place. Let's talk about two other acronyms that you'll hear once you start dealing in this more, is the MACs. The MACs are the administrative contractors, and they're the ones that actually, fall down. The private care to ensure that that the insurer that has been awarded a geographic jurisdiction in Medicare, A or B, AB, A, B, C, and D, because there are 4 parts of Medicare, whatever it is. And by the way, Medicare C is the Medicare Advantage. They just have changed the acronyms for it a little bit. And right now, so that's what a MAC does. But the local coverage determination are decisions made by a Medicare administrative contractor whether to cover a particular item. Because there's some that wouldn't cover, or initially there were some that wouldn't cover home sleep testing. So why did they change their mind? Anybody know? Because it was cheaper. Oh, and all of a sudden now they didn't do it. They didn't do it like 5-6 years ago. And I kind of lost 2 years because of COVID. I don't know if y'all did or not. So my time frames are always messed up a little bit. But they were not going to allow home sleep testing. And then all of a sudden now, what do the payers do? They said that's their primary screening tool. Let's do HSTs for a primary screening tool. And most sleep labs, what did they do? They went out and did home sleep testing as a screening tool. And it certainly has its advantage, unless you have comorbidities. We know all that, and y'all know more about that than me. But it's really interesting how the situation changed. And what was it? Follow the money. All of a sudden, now they accepted it when they didn't. There was no other documentation of it. Did these tests give better results here? Some of the technology today, it's true, they do. But we're talking 4 and 5 years ago. So they all of a sudden allowed HSTs. And one contractor did it, and they said, well, that makes sense. So another contractor did it. So let's identify, and we're going to get to actually looking at your sleep lab as well. But remember, when you look at your sleep lab, you need to make sure that you are following the rules set forth by all these contractors. So find your state, and I don't know how well you can see it back there. I'm here and I'm old and I'm not wearing my glasses, so I need to do this. But anyway, look at the bottom. In the areas of Connecticut, Illinois, Maine, Illinois has a private payer though, Massachusetts, Maine, Minnesota, New York, Rhode Island, right? Huh? Yeah. Oh, Tennessee. Yes, you have one, and that's Palmetto GBA that regulates your LCD in Tennessee. But these have no regulations for the testing of a sleep patient. They don't have any set forth. That means there's nothing that's regulate of what that lab needs to do. So what are most of them are not doing? It's hard to say most, but quite a few, they're not getting accredited. But because of that, they're getting some recoupments, especially on the CPAP side. Anyway, so you can file this out, and what the LCD number means, that's the LCD, that's the number. If you actually went online and put LCD and typed in that number, it will give you the regulation that you have to follow for the sleep lab. So it's really good to go out and take a look. One of the things we do as an accreditor is we make sure you're following that LCD. And there's some really interesting things there, because some will only allow certified, and we're going to go through it, but some will allow only for boarded physicians to read it. But some of the accreditors will allow a boarded physician that's pending the test or, waiting that to read it. But if it's in one of these areas that cause it, they could get a recoupment. So you need to be aware of what the rules are in your area, because it's not all about what the accreditor says or what your lab thinks they're doing. You need to make sure you're following the LCDs for your area in the sleep lab. Let's go through some interesting facts of LCDs that you might not be aware of. One of them, so this slide's very crazy. You can see it. I'm just going to kind of talk about it itself. But as you can see, 4 out of the 7 LCDs, they require the following credentials for the technician performing the sleep service. So that's their credentials. And if you are performing a sleep service, you have to have these credentials. And OJT is not on there. Can you do oversight? There are some ways, the workarounds, like some of them do it in a hospital, like these critical access hospitals. And if your therapist, happens to be in that hospital at the time, you might be able to get away with it. But that being stated, this is what they're saying. How is this important? Because if you don't do it and they monitor it and find out about it, they can actually come back and recoup the money that you just got for that testing. And who does that? I'll show you in a minute how that works. So look at the difference. So differences in 405 and again, if you want to go back and look at the numbers without putting the states in, these are the numbers that coincide with this slide. So without going to it, but what is interesting is so it says RRT right on this side over here, but the credentials not RRT, but they also have to have the SDS, or they're not qualified to do it. And that's only in some states, but that's okay. That's 2 of the ones that are there. Some of them excludes the following credentials. So RFFT, CRT, RRT. So some of them, RRT is excluded. Okay, so I found that unusual myself. That just happened in some of them. And 3 includes the following credentials, and it just goes on. That's there. So anyway, pull up the LCD, take a look at where you are, what state you're in. If you can't find it, call me. You have the access. They'll give you the number, and I'll give you my card. And then I'll send you all to somebody that knows more about this than me, and they'll answer your question. Now, but look at this, interpreting physician. You would think that would be simple as well. It is not. And remember, you think a board-certified physician, well, the answer is yes, a boarded, certified, sleep-boarded physician can always interpret it. But look at what some of the LCDs say. They includes the following, ABMS. But look at this, includes one of them, and that one excludes these credentials if you have it. And one excludes a fellowship. If you had a fellowship in sleep, can you do it? Not unless you're boarded in sleep. And these don't match up. See over there it said sleep certification issued by all those. They don't all match up. So how do they pick and choose? Actually, I can tell you one of the things that happened is one of the LCDs came out and they happened to be they ignored the DOs. They just put MDs. I don't think they did it on purpose. Well, the person that came in charge of the Wisconsins, they happened to be, and the medical director happened to be a DO. So what was the first thing they did? They changed it to a DO and MD. But there was nothing wrong with that. It's just, but before that, they could recoup that money that was paid because you did not meet. They had a DO actually reading that survey. Excuse me, not survey. I do surveys. They do testing. But anyway. Okay, let's take a look at why. OIG. OIG is a big thing. OIG is Office of Inspector General. When they call, you listen. There is no doubt about that because they have all the power. They can do everything. They're even the research thing of most of the Medicare. They're the ones that do the policy, adhering to the policy. And What they did here is an OIG analysis of Medicare payments for central procuring terminology for those codes, which total approximately $415 million, showed high utilization associated with these codes. They did an audit. They did an audit in the Midwest. What they found is hospitals were using these codes. The hospital sleep lab did not have a separate accreditation. They had to recoup over $4.5 million because they were not accredited when the LCD said they had to be. Hey, who got all that money? The LCD, the payer, got every bit of that money. So that was to an advantage because they weren't meeting that. Let's take this a step further. Individualize. Medicare, when they start doing audits of what your services are, and as I say this, realize you're ones doing the testing, but realize when you're doing the testing, everything you document is something they can review. So the importance of what you do, even more so, again, always goes back to money. You want to take care of the patient. We know that. But everything you do tracks back. And they could do that audit. They could actually take it down to the scoring of that and say, nope, you didn't do it right. This is what's going to do. Have they ever done that? Kinda. So what happened here is they audited, and this happened about 3 years ago. They audited services, and this doesn't sound like a lot of money. But I'll tell you why factors matter. What they did with the Medicare billing requirements for 96 beneficiaries associated with 161 lines of service, they submitted Medicare claims for the remaining 4 beneficiaries with 5 lines of service, and they did not comply, so it said overpayments of $3,127. That's not that big a deal, right? What do they do, though? When they do that, they extrapolate. If you did so many tests, they say, well, that's a percentage of how many tests you did. So of the 3,000, they actually had to recoup 12,000. There was one in Texas. There was another one in Texas that the OIG did. It was about 6 years ago. I didn't put this on there, but this was really hit the bank. They said there was a software glitch. I'm just telling you what they said. And they ended up billing for 2 studies when they actually did split night studies. Medicare caught them, or that mistake, whichever, because they did not get prosecuted, by the way, because they said something with a software glitch. When the person came back, they assigned it. Believe it or not. But anyway, what happened was they were fined over $40 million. Did they pay it? Nope, they went out of business. But they found it. They found it because all their billing that they did over a 10-year period for split night was actually for individual was actually split night studies. And we know that's another code. Every year when we talk about the OIG, every January, they actually do research of where the biggest payments. Sleep, way back, was never a big payment. Well, right, but through the trend, sleep keeps creeping up there. And now if you look at their end-of-the-year audits the OIG does, sleep is in there almost every time. Now, it could be under CPAP. I'm going to break something here. For those of y'all at home, it's okay? Okay, I didn't break anything that time. Okay, he said I could do it. So he said I could. So where was I in that state? No, okay. But interesting enough, in the whole payment scheme of what is going on, the OIG is monitoring sleep even more and more, especially when CPAP became more prevalent. Now they have many different devices. Dental devices have gone up from 2% to 12% that's out there today. So anyway, the OIG takes this, and so if you think you're the stepchild that never gets looked at, you are wrong, because it's all about expenditures, and that's how they're doing it. So how can you go on and what has happened? Well, ACHC, we're not the largest accreditor. That is AASM. But what happened during the pandemic? We had over 200 labs, and we still have about 700 accredited. So we have a huge number of labs accredited with us. We had 200 labs closed during the PHE, and only about 70% had opened back up, but they opened up and they cut capacity. Some of it, though, is interesting. Some of the capacity they cut is because they couldn't get the sleeping machines. I won't go into recalls or anything, but they couldn't get that. And by the way, they couldn't get techs to serve it. They can't find techs. Y'all know that better than me. I'm sorry, you all know that. Y'all means you know where I'm from. So we experienced many hospitals converting labs to the COVID. They changed in protocols for accepting patients. They changed protocol for infection control process. Obviously, it's costlier now. You have to take, we probably always should have taken these precautions in infection control, but we didn't. We should have. And these are some of the things, and it's a little bit more costs more. Equipment recalls, you know about that. An increasing of home testing. You know, labs that survived also had another aspect of adding home sleep testing to the overall lab. Is a good, and why is that? Because that's what insurance providers wanted. Not so much Medicare, but remember, many of the patients we test are not in Medicare. Well, it is a huge percentage though. Sleep center monitoring. What should you take a look at? Do you have the right licenses? Everything on here is what we look at as an accreditation. The reason it's here is because if you go to the OIG or the LCD, they require these. Do you have a listing of governing body? Who owns it? Who's going to actually control at the end of the day where your sleep lab? And if you are in there just doing testing and you don't know this, you need to go back and just open up the book. I realize it's boring reading, but taking a look at it and seeing, do I really know what makes this lab run? That's there. Copy of fair label, resume of applicants. All the other stuff is pretty self-explanatory. Marketing materials. Complaints. Oh my goodness, guys. If you get a complaint and you don't document it, you are in trouble. That's one of the biggest things OIG looks at upon is when they go in there, and that's with home health agencies, that's with DemiPost, that's with hospices. They want you to address your complaints. What you call a complaint is up to you. So keep that in mind. You know, I just didn't have a good night's sleep. Okay, I get that. But what if a complaint is, I didn't like the tech, they didn't listen to me? Or the complaint is, you know, I don't think I got a very valid study, and this is why. If you don't respond to a complaint, that's when they get upset. And they use those complaints to, hold money back, or say, you need to do the investigation. And what does the OIG do? They don't do the investigation themselves first. If they're accredited, they come to us first. And we do the investigation. We don't see it as much on sleep labs as we do DMEs. And part of that problem, part of that issue is a lot of sleep labs are inside hospitals, although we've seen that change. We've seen that change just a little bit. So you want to document the training of everything going on. You need to have policies on what you do. Now, you know how to set up. One of the things we don't run into with either therapists or sleep techs going in there, every one of y'all are so well trained in how to set up a patient. I mean, it really is phenomenal, and we see that consistency across the board. Now, we have seen some of the take shortcuts that they probably shouldn't do, but that being said, you know what to do, but are you doing it? And the one time you don't do it, they could be a person that's screening it. What do I mean by that? Anybody ever heard of secret shoppers? Well, secret shoppers is really big in the home health industry. Some of the sleep labs, not many, but we have heard it. What a secret shopper does is they will actually call your lab, they will actually come in for a study, and they will see how you set them up and how you educate them. And they are a Medicare employee or contractor of the LCD. That does happen. They'll give you a call. So we've seen that, and we usually see that when they're investigating what they think fraud and abuse. And just a real quick thing, fraud, let me talk about it. Abuse is the unintentional lack of knowledge, and fraud is intentionally defrauding. So keep that in mind, because we have seen some abuse that they've done and they don't really do anything with it. They just said it was a lack of knowledge. But the more knowledge you have, the better it is. Okay, you need to have some type of meeting ongoing that you educate your staff of what's going on. You know, are there new standards coming out? What does your sleep doctor or your medical director want you to know? What kind of feedback are we getting? Are we getting that satisfaction surveys? If you are not doing satisfaction surveys, that's one of the biggest things that CMS looks for. When I say CMS, I mean the contractors. They look for, are you getting feedback from your patients that you set up? And by the way, you want to know if you offended somebody. Sometimes no matter what you do, you're going to make that person mad. I get it. I get it. I understand it. I've been there. I've made quite a few patients mad. That being said, that's not your intent. And you know what? We all have bad days. Just keep in mind when we have a bad day, your patient doesn't need to know about it. And they don't need to know how much you're in conflict with that sleep lab. You're there to perform a job. I know that's obvious, but I want to say it because it's so important of the patients, and feedback is really key. And you don't want them picking up the phone and call Medicare or your Blue Cross Blue Shield or your Humana. Why is that? Because you could lose that contract. These are things that we don't think about when we're doing the testing. And I don't want to scare you all when you go away. That's not the point. It's just to be very cognizant about what you're doing when you're there. And that's why PI and performance improvement is so important in what you're doing. I always check my time. Oh, yeah, we're good. We gotta get you out of here early. Ha! You can go have that hot toddy. Okay, beer. One of the other things, too, is cleaning equipment. Do you access cleaning equipment? Is it all marked? Is it all marked of what you're doing? Did you document when you clean it? Is it written down? We had one lab, the OIG did a report on, a person complained, they thought they got exposed to AIDS because the patient before them was HIV positive. Now they were on Harvoni, so they couldn't have transmitted it. But that being said, they thought that it was exposed, and so they went down the line, they pulled up records, I don't know how they got them, and they made a complaint. So know your cleaning process and do it, it's so important to do. And not only that, you're protecting yourself as well. Those are the little things that we know that we take shortcuts on. But don't do it, and these are the reasons why, when you're monitoring what's going on. And one of the things PI does is in performance improvement, you know, how you're improving yourself or quality, it takes a look at, am I documenting the cleaning? Am I documenting what's going on? Am I documenting, there was that red speck of blood on that mask for some reason. Did I really clean it off or did I really expose it? So I think that's all so important to do that sometimes we forget. You know, it's the end of it's in the morning, I'm tired, do I clean it? It's very important. Okay, we're on the final start here though. Sleep rooms can contain monitoring equipment, recall records, and do you have HST equipment? If you do, clean it, do it per the manufacturer's the documentation for the home sleep testing, and you want to make sure you're following their protocol for cleaning it. You can go above it, just make sure minimally, I can say that word again, but I'm not, that you are following what they are recommending for you to do. Okay, now we need to adapt to industry changes, right? We talked about infection control protocol. We had one lab that was a huge lab. What did they do? They brought in for all their equipment, because there was a 16-bed lab. What did they do? They brought in ultraviolet equipment, and they put everything under the light, which kills everything immediately for the protocol for COVID. And they did a tremendous resource there, but they thought it was needed. for all their bed linen, their rooms, they just zap it. Real expensive. They had a lot of money to do that. This computer is coming down. Increased home sleep testing we've seen. Creation of HST accreditation. Not everybody does HST accreditation, but really the focus of that is who's reading it, who's interpreting it, and are you recycling the equipment appropriately. Okay, contracted entities. Who is doing the study? So what we've seen, and you all might be approached it someday because sleep techs are so hard to find. What happens in critical access hospitals or small hospitals? They can't afford to open a lab, right? But they are 60 to 80 miles away. We see it in Alaska, Montana, Iowa. And they're 60, 80 miles away. So what do? They contract with a company that brings in sleep equipment. They bring it in, they set up a room. They set up a room, it's meeting all requirements. They're monitoring it, they're video recording it, and it works well. So that contracted entity though, so it's interesting. So I own a hospital, but I don't have that. But if I own the hospital and I'm contracting that entity, it's me that's doing the billing. So I need to make sure that contracted entity has everything that is required by the LCD and me as a hospital. That trend has gone crazy. And if you're not aware of it, it really is in rule because they don't want to lose their patients, but they want to be able, because they're community access hospital, that means, well, community access or critical access hospitals, but they're really small hospitals. I mean, we had one that was 8 beds. The whole hospital was 8 beds, but they wanted to keep their sleep lab. They contracted with the entity, and once a month they were really busy. They brought in a sleep lab, and they had enough patients over a month. They were doing 4 studies in 2 nights for patients in 2 nights. So, but they brought it all in, set it up, and then left. But the hospital owned it. They set it up in a hospital room. So interesting type thing, but they didn't want to lose that patient. They can do that. So who's accredited? The hospital is accredited though, or that entity is accredited. That contractor is not.
So the contractor does not have to be accredited in that scenario?
Okay, so it's okay. Go back to follow the money. So here's how it works. Yeah. So it's the hospital's responsibility because they're doing the billing to make sure. Because who gets the recoupment? The hospital, right? So they're the ones that are responsible for it. So they need to contract with somebody. Now, several of these contractors in the areas, they are accredited, by us. We do, because that's kind of a pass-through type thing. But they don't need to be accredited, but they need, remember, if I go in and take a look at your study, you're billing for it, you have to have all that documentation. So I want to say, well, you did the study, how do I know that person's a registered polysom? How do I know you have the recordings that are needed? You have to show that to me. Usually contracted entities know that, they have it already, and they're the ones that actually go through the accreditation, but it's the hospital part of it. Some administrator there is taking part in it. We're seeing that, we see that a good bit, more and more. And the LCDs like it, right? Because it's cheaper for them. The payer likes it than having to move them, 150 miles to have a sleep study. And they get treated. So I'm going to end up with just saying your accreditation options. These are the 3 accreditors that do sleep labs. What is interesting, though, so that's us, ACHC, AASM. That's a 5-year, and the Joint Commission is a 3-year. And this isn't my data. This came from Sleep Review magazine. One of the things that happened recently was very interesting is that in the Midwest, they had accredited hospitals that were accredited by the Joint Commission. They accredited the whole hospital, right? They accredited the whole hospital. What happened was, though, unbeknownst to us as well, unbeknownst to the hospitals, the LCDs changed it and said each sleep lab, it's not in every LCD, but each sleep lab had to have their own sleep special accreditation. So they went back and recouped it. So you can't just get a hospital accreditation. And we do hospital accreditations as well, ACHC, but we have to have a separate sleep accreditation because otherwise it gets recouped. Could get recouped. One of them just let it go and said, from now on, let's do it. So anyway, this is from Sleep Review that's there. This is who I am. I have a lot of experience in sleep. I have a whole sleep staff that just works with between CPAPs and between sleep labs, getting accredited. And I really hope today was educational for you because there's so much in that business that you're not aware of that goes along behind what you do. And I said, the more, and I do this a lot speaking at sleep societies because we haven't heard this before. It's there. I realize it's not the most exciting topic in the world, but it's all the things you need to do. So any questions? Yes? Oh, I'm not sure I can take one from you because you know more about this than me.
The lab that you said that was billing twice for 2 nights, but doing only one study, were they doing the 4 hours up till midnight and stopping the study and then starting it after midnight and doing another 4 hours? Is that how they were doing it?
I can't answer.
Please repeat the question.
Oh, yeah, sorry.
I'm going to get that slide. Sorry.
What am I doing?
Just step aside and answer the question.
Okay.
I'm going to put up the QR code for you.
Oh, okay. It was scary. He just said, just get out of my way. It's kind of like we're married, right? Just go. Okay, I've been married 40 years. I can get away with that. Actually, it had something to do with that because there was something in their software that did the change of date, and I don't know if it was 12 midnight or the next. I don't know how that actually worked. All we saw was the results of what happened. And then, now that you said that, that's making a whole lot of sense to me. Because they automatically set up an automatic billing, right, that was done. And somebody should have screened it and looked at it. Because it was a significant amount of money. Significant amount of money. It was a huge sleep lab, too. From state of Texas, by the way. Yeah, it was in Texas, yes. And it was a huge amount of money. They did come back. Nobody went to jail because they said they did not believe. I mean, they had spent a lot of money for lawyers. They did not believe it was intentional. I didn't understand how that could happen, but I haven't seen that. I wasn't involved. But nonetheless, they had to pay all that money, and then they just went out of business and didn't pay anything.
There are sleep labs. There are independent sleep labs that were specifically, not anymore because of litigation, but there were independent sleep labs that were charging both codes and putting the date change at midnight.
Okay. Intentional. So, and for the people at home, since I didn't repeat the question, they were just suggesting that the one we talked about was recouping, doing the dual study. Could it have been that another day happened? They had a 4-hour span, another day happened, and then they billed for the second part of it automatically. Some people did get caught for that. One of the reasons, though, accreditation got mandated is for specific, because we look at that. We go in, we look at that, and you want us to find it. Nobody here is intentionally, if you're here, you're not intentionally trying to fraud the government. You're not. If you're here, you want to. I say that because you're here trying to get educated in what's going on. But I'm sure there are people out there doing that. But, of course, there's not as much. If you're going to do fraud to the government, there's not as much. They're not paying exorbitant amounts for sleep studies today. So, I'm sure that's not where they would go about doing it. But you are right. There is an intent, and we've seen that. We'll just go on and code it because we did 2 studies. It was the same time. Anyway, what other questions?
I know that the LCD that covers Alabama and Tennessee made a change in March on who can run Medicare studies.
Mm-hmm.
The way it's worded, some people worded that oversight could be done by
So that's the way I understood it. That being said, we had an attorney look at that. Somebody had an attorney, and we have an attorney on our board that's a healthcare attorney. And they said if you have oversight, because oversight was in there, and oversight is a loosely determined of what oversight is. Because if you look at Medicare, they have a definition for everything. If you look at it, it doesn't say what oversight means. So that was their interpretation of it. Any other questions? Guys, I hope this was helpful. Let me know, because I enjoy doing these talks, mainly because it's educating people that do sleep every single day.